So energy is easy to think about as 1, 2, 3. So remember, 1 is glycolysis, 2 is the Krebs or citric acid cycle, and 3 is the electron transport. Shh, 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 shh. Okay, so glycolysis, the substrate is glucose in the blood sugar, 9 different pathways to making pyruvate. You'll see that many of these have red lines going across, which are the known poisons which inhibit the enzyme. And here we see fluoride. So fluoride is an inhibitor of this particular enzyme. A little bit later in the hemoglobin, we'll see that there's another aspect where fluoride inhibits. So there's different chemicals that can actually inhibit the flow. But inhibitors of enzymes are usually toxic metals. Some chemicals, and certainly radiation, will damage the gene which expresses the enzyme. So radiation damage is really serious because it may be reversible, it may be irreversible. Okay? But toxic metals are relatively straightforward because all you've got to do is get out the toxic metals or the chemicals once you've identified them. So what is a toxic metal? Every enzyme requires cofactors, in other words, elements, minerals, to activate it, to get it go, like keys being put into a nuclear reactor. You need a certain number of keys to get it to work. Now, many of the cofactors are things like zinc, molybdenum, iron, etc. So common elements, common minerals. Now, in the periodic table, in the same columns, or sometimes further down, usually heavier, are elements which are toxic. Okay? For instance, in the same column that we got zinc, which is a good cofactor, the bottom of that column in the transition that we got mercury. And mercury will therefore displace in greater quantities zinc. So enzymes which use up zinc can be replaced with mercury, which inhibits the enzyme from working, which makes mercury a toxin, okay, because it inhibits the enzyme from functioning, whereas zinc would be the normal cofactor. That's what a toxic metal is. So toxic metals and chemicals can inhibit, potentially any of these enzymes from working normally. Okay, so when we come down here, we see pyruvate is the end of glycolysis. Then we've got this interesting area of crossing the mitochondrial membranes, the outer membrane and the inner membrane, of converting pyruvate into acetyl-CoA. And if we take a closer look at that, we see that the end of pyruvate goes across needing alpha-lipoic acid here, but B1. And this B1 is the active coenzyme of B1 called thiamine pyrophosphate or diphosphate. So thiamine pyrophosphate is the active coenzyme. So thiamine would be your vitamin, which you would get from your wholemeal bread, your liver and your yeast, etc., in others from your diet. But you then have to activate it in the body to thiamine pyrophosphate to get it to work. So if you've got a genetic polymorphism, which means you can't activate enough thiamine to thiamine pyrophosphate, you may have a problem in converting your pyruvate into acetyl-CoA, so you'll have a genetic predisposition to building up lactic acid. Okay? That means you've got to supplement with a greater amount of thiamine pyrophosphate to get this system to work more effectively. Now you'll see here, if the pyruvate builds up, we shunt it by lactate dehydrogenase into lactic acid, and that'll grind you to a halt and produce greater amounts of pain. So anybody who has a high level of lactic acid should be looked at very carefully with B1, thiamine pyrophosphate. Now, it's possible they may also need, or maybe instead, alpha-lipoic acid, which basically here recycles the B1. And to recycle the alpha-lipoic acid here, we need B2 and B3. So now for this little part here, we need B1, B2, and B3. Now the final part is putting this onto CoA, which is the active form of vitamin B5. So the CoA comes in here, and then this makes acetyl-CoA. And CoA is the active form of vitamin B5, or pantothenic acid. So now, just in this little part between the mitochondrial membranes, we've got B1, B2, B3, and B5. Which is why, as I said, if you, in doubt, use B complex, because you've got everything in there. But you've got to take into account polymorphisms where a person may need thiamine pyrophosphate rather than just straight thiamine. Now, when we spin the Krebs cycle, as I said, we produce NADH, which is the reduced form of vitamin B3, and we produce FAD, H2, which is the reduced form of the coenzyme of vitamin B2 or riboflavin. Now, the spinning of the Krebs cycle, the speed is like a cycle. The faster we go, the more energy you produce. Okay, so when you want to exercise, you want to spin it faster. And the speed of the Krebs cycle depends upon T4 and T3. So these are the thyroid hormones. So when you're hypothyroid and you've got a sluggish thyroid production, you get a sluggish metabolism, which means basically that the speed of the turning of the Krebs cycle becomes slower. And as a result, you produce less energy at the end of the day. Okay? So this is really important. So if you don't burn up your acetyl-CoA here at sufficient speed, you get a build-up because it's not being burnt. So it's your fuel going into the furnace. You've got more fuel coming in than going out. So what happens is it shunts it backwards here into producing fat. So we then store the acetyl-CoA here as palmitic fats, stearic, arachidic, and bohemic, which are all saturated fats. So this is the mechanism of why we produce fat. So if we produce fat, everything you eat turns to fat. It's because you're not burning acetyl-CoA here in the Krebs cycle, because you're deficient in the vitamin Bs usually to get it to work. So spin the Krebs cycle depends upon thyroid. Now there's something I've discovered really, really interesting, which we'll talk about this afternoon, is why a lot of people have got thyroid problems. And I came across this by accident because there's an enzyme which puts the right charge on iodine. And I want to share that with you this afternoon because I think a lot of people don't use the right type of iodine or can't ionize the iodine in the right way to add to the tyrosine to make T4 and T3. Really interesting this for a reason which we'll discuss later on. So when we get to producing NADH and NADH2, these protons or H's cross the mitochondrial membrane and build up in the membrane here. Now at the same time we have electrons which are given off from here, and these electrons are converted to or carried by CoQ10 or coenzyme Q10, ubiquinol, from complex 1 to 2 to complex 3, and then by a carrier protein again called cytochrome C to complex 4, where at 4 molecular oxygen comes in, we activate the ADP to ATP, and the end result is water. So the whole of this rather complicated electron transport just involves two substances really, CoQ10 and cytochrome C. Now cytochrome C again we'll see has an important connotation in the production, as we'll see, of hemoglobin and heme this afternoon. Now this little bit at complex 4 is important because this is where the real energy is produced and where oxygen is made and reduced to water. So if we blow this up, complex 4, we see we have molecular oxygen going in, and normally this is reduced by the addition of 4 electrons. So when we add univalently, which means 1 electron at a time, we produce superoxide. This is oxygen, O2, with a dot. Okay, that means a dot means an extra electron. When we add 2 oxygens, 2 electrons to oxygen, we get H2O2, which is hydrogen peroxide. Now, hydrogen peroxide is not a free radical. It's a reactive oxygen species. Pour it on your skin and your skin oxidizes in no time, okay? But it hasn't got an extra electron, okay? So it's considered to be a ROS, or reactive oxygen species, but not a free radical. If we add 3 electrons, we get hydroxyl radical, which is a highly reactive substance with a dot. And when we add 4 electrons, we get water and molecular oxygen. So normally in oxidative processes of producing energy, we put 4 electrons on in one go. But in every oxidative reaction, anything up to 5% of normal oxidative reactions produces univalent reactions. In other words, we produce superoxide and the other reactive oxygen species. And in certain other circumstances, we do this all the time. Now, why were we created producing reactive oxygen species which basically destroy us or kill us in the end? The answer is to kill microbes. Okay, so all our white cells use this to kill microbes. If we didn't produce free radicals, we'd be dead within hours of being born. So the ultimate chemical that our white cells use to spray bacteria and viruses and pathogens is free radicals or reactive oxygen species. So we need them, but we don't need them when we don't want them. Okay? Now, as we'll see in a minute, the normal wired mechanism of dealing with free radicals is certain enzymes to reduce the free radicals to molecular oxygen. And if they don't work properly, then we use antioxidants to act as blotting paper. But this is a particular area of interest here. Now, we're going to come back to these two later on, because if we produce superoxide, this will go on to be reduced to hydrogen peroxide, and then we'll go on to produce eventually water and oxygen. But if we get a build-up of these, we get a lot of inflammation and a lot of damage to tissues. And one of the ones we're very particular, and you will with your patients after this afternoon, is the eyes. So the eyes you're only given two of. Some may have one, some may have three, but most people only have two, all right? And if you damage those eyes, it's more or less irreversible as far as we know. We may be able to reverse things one day, but at the moment we can't. And when you lose your sight, it's very sad because there's no going back if there was something that you could do. I had a case a few weeks ago of a lady. I said, you've only got two eyes and you're losing, damaging it. And she said, no, she said, I've only got one. I lost my first one in childhood with a cataract. She'd already had eye problems, reactive oxygen species clouding the lens over, and she was losing the sight of the second one, and because she was pouring hydrogen peroxide in the back of her eye. Now, do you actively pour hydrogen peroxide to the back of the eye? No, of course you don't, okay? But you do when you create it in the back of your eye, and you pour it on, it'll oxidize. And I can tell you everybody in this room who's doing that, everybody who's wearing glasses, is pouring hydrogen peroxide into their eyes, okay? You're losing your rods, which is why you're wearing glasses, okay? Your pupillary light reflex is no longer working properly, and we'll prove that. And probably most of the rest of us who don't wear glasses have got some degrees of it. Okay, so we all produce peroxides. And why is it the back of the eyes? Because there's a particular waveband of light, which we'll talk about this afternoon, which activates the production of superoxide and peroxides in your eye if you have an abnormality in the production of your hemoglobin due to hypoxia. Okay, and this is the first place you see. And when you ask the patient how your eyes, they'll start to tell you. And they'll say, well, they're not as good. It's funny, why did you ask? And you describe it. And they say, well, I'm so glad somebody's actually for the first time asked about my eyes and that something could be done. And because they know that they're getting worse. And it's not just accommodation. It's not just to do with reading. It's the ability to, get the pressures right between the aqueous and the vitreous humor, damage to the macula. This afternoon you'll understand exactly what macular degeneration is, and so many other cataracts and other visual problems. Okay, so let's have a look at the big issue, which is the hypoxia. Now, a couple of weeks ago we did, probably a month ago now, we did a seminar for ARS, the kinesiology group, where we just did the whole day on hypoxia. And what I've done is I've précied this and taken out some of the complementary parts. It's on which is on the website. So if you want the full seminar, it's on our website now. What we did to start off talking about hypoxia, we looked at the 10 most common medical symptoms that people go to a doctor or practitioner for. And the first one, surprisingly enough now, is fatigue. So fatigue has become the biggest reason for why people go. And they can wrap it up in all sorts of ways. They're tired, unresolved tiredness. They sleep, but they feel tired when they wake up in the morning. Or they can't sleep when they get tired that way. But they're all basically tiredness or fatigue. Followed by backache, which is great for us osteopaths and chiropractors. We don't want to cure that too much, do we? Otherwise we won't have any patients. Okay, but we'll see that pain and fatigue actually are linked. We talked briefly about the linkage with lactic acid. So there's a lot of reasons sometimes there's an overlapping here. Colds, in other words, respiratory infections. Okay, respiratory. Abdominal pains. the irritable bowel. Okay? Anxiety and depression, big because the number of medications that are prescribed for this. And memory loss, and with the memory loss I put visual dysfunction, okay, because there's a close connection, because the eyes are considered to be the stalks of the brain. So what goes on in the eyes is going on in the brain. Arthritis, skin problems, and followed by chest pains. Okay? So does that probably doesn't surprise you very much. On the other hand, perhaps some of the, like the fatigue and the backache are, but you'll notice that, you know, basically you're looking at pain, muscle fatigue, in other words, symptoms of low energy, low immune system, okay, with colds and respiratory problems, anxiety and depression due to changes in brain chemistry, memory loss again, and visual problems, which may well be due to lack of energy of the neurons firing correctly. Arthritis or degeneration. You know, one of the quickest ways to degenerate a joint is to pour, and this has been proved in laboratory, pour hydrogen peroxide into the knee. You won't have cartilage for very long, okay? It dissolves quite quickly. So if you've got a high level of hydrogen peroxide in your system and it attacks a joint, then you'll get osteoarthritis. Right? So we'll see there's a link here with the energy production. Chest pains may be serious, may not. It could be ischemic heart disease, or maybe not such an important issue. Now, the 10 most common diseases that cause death, a little bit more serious here in 2012, is coronary ischemic heart disease. Okay, no big surprise as it's a phonocardiography seminar. Okay? Cerebrovascular accidents, in other words, strokes and transient ischemic attacks, malignant neoplasms of the lung, pneumonia, diseases of pulmonary circulation, bronchitis, infections, malignant neoplasms of the breast, liver, diabetes, and hypertension. So certainly we could put a lot of these into the category of lack of oxygen or lack of energy. Ultimately, particularly, we know that all malignant cells are hypoxic. This has been known for 80 or so years. So hypoxia is a condition which part of the body or region is deprived of adequate amounts of oxygen. It can be generalized or local. Symptoms, if it's a gradual onset, maybe feeling a bit light in the head as if you're climbing a mountain, numbness or tingling of the extremities, nausea, tiredness, visual deterioration, memory loss, feeling the cold. Richard, when you came out and said hello just now, your hands were like ice. Okay, we need to stick an oximeter on you and see how much oxygen you got going around in the arteries there. So feeling the cold and degenerative changes. Okay, so classically you see pale hands or blue. Okay, when you see somebody's blue, they are literally blue with cold because that's the color of deoxidized, deoxygenated hemoglobin. So if it's a rapid onset, you could have ataxia or balance problems, confusion, disorientation, hallucinations. These would be people who suddenly have loss of oxygen, behavioral change, severe headaches, reduced level of consciousness, papilledema, which is pressure in the back of the eye, breathlessness, pallor, etc. So if you want to get a quick fix of that, just go up in a high altitude plane, and with the lack of oxygen there, they lose all orientation, the pilots. The pilots are taught to trust the machine, the dials here, completely, 100%. Don't trust their eyes of where they are. They have to trust the machine. The machine, the devices here, the automatic will correct the pain. Okay, they may not be able to do that because they'll get disorientation of where the land is and where the sky is after they look at the dials. If hypoxia is severe, the tissue may eventually become gangrenous. Now, that's a nice little picture before lunch, isn't it? Okay, that's when you've got real bad hypoxia. Now, some of you may have seen ulcers on people's legs. Sometimes they're called varicose ulcers, aren't they? And it was one of the very first things I learnt when I started doing the nutrition part of applied kinesiology back in the 1980s. I was plagued as a teenager, around 12 to sort of 16 years of age, with mouth ulcers. Did anybody else get mouth ulcers? Yeah. And sometimes it was because you bit your cheek, sometimes it wasn't, they just appear. And the worst ones of all were if they came on your tongue, okay? And, you know, I went to the doctor, went to all sorts of people, and, The only thing that ever gave relief was actually vitamin C lozenge on it, but it stung like mad, but it did help the healing a bit, but never stopped them from coming. And then eventually sort of grew out of them a little bit. We even used potassium permanganate as a solution there, but nobody really got to grips. Nobody knew what it was. And I was treating somebody back in the 1980s who had them, and I just went through the kit, and believe it or not, pyridoxal 5-phosphate came up, okay, or B6. So I started testing everybody with B6 or pyridoxal 5-phosphate, and it was the answer to the ulcer. So after that we realised, we knew a bit more about the chemistry, and when the hormones kick in young teenagers, they need a lot of B6. Okay? And one of the things that knocks the B6 out of kids, and adults as well, is chlorine. You want to knock the B6 out, go in a swimming pool. Okay? It won't take you long before your B6 level is really rock bottom. Okay? Chlorine inhibits the conversion of pyridoxine to pyridoxal 5-phosphate, which is why a lot of kids do a lot of swimming and they get a lot of mouth ulcers. Okay? Now, a lot of adults get ulcers in other locations, stomach ulcers, for instance, and they get ulcerations in the legs later on when they get varicose ulcers, okay? Which is because they got varicose veins. And what are varicose veins? Varicose veins are loss of collagen, isn't it? Because you lost the support to the vein wall. And what is the major factor in collagen to give it support is pyridoxal 5-phosphate. And if you're B6 deficient, your homocysteine level goes up and your collagen goes down. So you begin to see, circulation problems, B6, teenage time, it all threads together. Okay? Typical reaction of vitamin B6, or more specifically, pyridoxal 5-phosphate deficiency. So next time you see a person with a varicose ulcer and they're all strapped up and they're putting all this stuff on their legs and being dressed every day, just get them on pyridoxal 5-phosphate. Okay? It'll be the last thing they'll ever get prescribed because it's not a prescribed, as far as I know, it's not a prescribable medicine at the moment. You know, it's not. B6 is. You can find B6 in MIMS, but you won't find pyridoxal 5-phosphate. So these people are not deficient necessarily in B6. They may be. We were just talking about a new care home which is being built near where we are in Marlow, and it's strictly for dementia problems. And we were just wondering, you know, whether they got flats in there, whether the flats would have cookers in there. Because if you've got patients who've got dementia, would you put a cooker in there for them to cook things on, because they wouldn't know whether they left it on or not. So the likelihood is they're having to have kitchens with a canteen of some form to look after all these we say elderly people, but they may not be so elderly now. And Jill said, oh, you can imagine the junk that they'll be fed, which will just make them 10 times more deficient. You know, in old people's homes and this sort of thing, you're going to get chicken, aren't you? And you're going to get awful vegetables. You won't get the vitamin Bs, you won't get the B12 in there, and you certainly won't get the B6. So they're steadily going to get worse and worse. You know, they're not going to get better in there, which is such a pity. But you'll get a lot of this, a lot of varicose ulcers, I can almost guarantee, in old people's home and things, you know, the number of people, because they're just not getting the B6 or pyridoxal 5-phosphate. Right, because hemoglobin, that's the red pigment in the red cell, is red when it is not bound to oxygen, deoxy, as opposed to the rich red colour that it has when it's bound to oxygen. So oxyhemoglobin is a very rich dark colour. When seen through the skin, it has an increased tendency to reflect blue light back to the eye. So deoxyhemoglobin, it shows up as more blue when we look at it, or cyanosis, so you get blue lips, blue hands, blue feet, etc. Hypoxia can result from a failure at any stage in the delivery of oxygen to the cells. So we know oxygen is in the air. So we've got to get it from the air into the mitochondria where it's used. Okay, so it's quite a long passage, isn't it? It's got to get from the lungs, the alveolar, across the cell membrane, across the capillary membrane in the lungs, across the blood into the red cell, so the red cell membrane, and into the hemoglobin molecule there. And then it's got to go around the other way, from the red cell, across the blood vessel, into the cell, and into the cell membrane, through the cell membrane, and through the mitochondria. So it's quite a transport. And there's only one thing that drives it into the cell, in your skin, in your big toe, or in your brain, or anything else. One thing that does that, and that the only thing is diffusion. In other words, the pressure is greater at the beginning of the whole flow than it is at the end. So in other words, if we filled this room up, if we increased the pressure in this room, air would flow out those doors. So the pressure in the anteroom there would be greater than in the antrum. Okay? But if the pressure was greater in the antrum, it would flow this way, wouldn't it? So the air would flow this way. So if we fill this with oxygen, oxygen would basically flow to there, right? And if carbon dioxide was greater in the antrum, it would flow the other way. Now, hemoglobin is that wonderful molecule that can transfer both. The heme molecule can lock on to oxygen and transport it one way, and carbon dioxide the other way. Okay? So carbon dioxide, the pressure is greater in the tissues than it is in the lungs, so it flows that way. Whereas oxygen will flow the reverse way, providing the pressure is greater at the beginning than it is at the end. So what got me interested in this is how do we measure as practitioners the problem of hypoxia, and what's the sort of history of it. And what we are noticing with the phonocardiography is that the vast majority of our patients, 80%, had small first sounds in comparison to the second. And this brought us back really with the very first one that we did today. So could we convert to the other computer? Can you pop the other computer on? So we see here, the first picture here is of a reasonable first sound in comparison to the second. Not brilliant, but better than that. And then if we look at this one, we'll see how small the first sound is in comparison to the second. So this is a healthy person, good resting period, good first sound, second sound, but not high enough. Certainly not twice the height. So if we convert to the other computer now, we'll see then we've got Sylvie's coming up on here, hopefully. There it is. So we remember we looked for the gap, so we were clear in understanding where the first sound and the second sound. Now, I made the mistake with myself that my second sound was higher than my first sound. And so I came to the conclusion that this was my resting period. This was my first sound, this was my second sound, and I had a short resting period, first sound, second sound, short resting period, and I was about to have a coronary. So I started doing some vitamin E, vitamin C, all sorts of things, and within a month I'd changed completely, and it was fantastic. And then I realized I'd read the whole thing wrong. I just got a small first sound and a large second sound. So I did the cardinal error and thought I was dying, okay. And I go, so I wasn't as bad, which pleased me, which probably improved my health enormously, that I was relaxed. Okay, so you've got to be able to get this straight first. Which is the first and which is the second? So first, second, gap. Just look for the gap. Okay, first, second, gap, first, second, gap. So we can see here on Sylvie, the real problem is like the previous one here, is we've got a small first sound. Should we blow that up once? Let's enlarge that so they can all see. With this particular program, we can do a blowout. That's fine, don't go any further with it. Okay, so we can see it. So the advantage of the program is we can magnify it if it looks too small, but it's the proportion of the first to the second sound which remains the same. Okay, so again we can see we've really got, some of them are half the size of the second sound. This will produce a low output, cardiac output, okay, from the ventricle into the circulation, which must mean she's going to pump less blood, therefore less nutrients, and most importantly is less oxygen. So we've got 100% certainty now, we understand this, she'll have hypoxia. Okay, why? Because remember, the pickings of the blood is to the coronary vessels. And the coronary vessels are to supply the oxygen and the nutrients to the cardiac muscle. And what does the cardiac muscle do? It contracts to pump the blood through. So if it doesn't have enough oxygen and nutrients, it can't pump as hard. Okay? Therefore, the hypoxia is a vicious circle, because you don't pump so hard because you haven't got it, and therefore you don't get the blood round. So what do? These are people who are better for exercise. How do you like exercising? Okay. Yes. So some people say, I feel much better when I exercise. I have a brisk walk, a bit of a run. The best one is a howling gale out there. When there's a howling gale, you want to go out there, open your mouth up and get all the air you can, and people feel wonderful. Absolutely wonderful. They say, all the air at Beachy Head. I go down to Beachy Head at the weekend and just breathe in the sea air. What they're doing is they're hypoxic. They just love to get more fresh air in there, which makes them feel better because they increase their oxygenation. So some people will feel better for exercise, and some people will feel dead because they just simply can't get the oxygen to the muscles. At the break time, we were talking about probably one of the most common reasons for hypertension is this. What happens if you don't get enough blood, and particularly oxygen, to the brain, is the brain, through the hindbrain, puts up the blood pressure, basically. So up goes your blood pressure to increase the cardiac output. And it will do that through stimulating the sympathetic nervous system to make the heart contract harder. And it'll increase the amount of blood to the head, unfortunately at the expense of the blood pressure going up. So you get labelled, oh, you've got hypertension, you need ACE inhibitors or calcium ion blockers and so on, channel blockers. You end up on medication, but you haven't solved the problem. The problem is still there underneath. And the problem is usually hypoxia behind it, because you're just not producing enough oxygen being carried around, which ultimately means your heart doesn't contract. So when you do the cardiograph, 80% I would say now of the cardiographs that we've done over the year period, which it must be now, show a decrease in the first or second sound, which means the heart isn't contracting enough. Okay? And the reason for this is the cardiac muscle doesn't contract enough because it hasn't got the oxygen, in other words, the fuel being delivered to there itself. So hypoxia therefore became, I thought this is interesting, because in previous seminars, years over done, when the subject of hypoxia come out, we said, oh, check for B12 and check for iron. Maybe magnesium peroxide, something like that, perhaps CoQ10, and one or two slides and the job's done. Okay? Now we realise we've missed the most important nutrient of everything, really, far more important than magnesium or anything else, is why is a person hypoxic? In the first place, because if you've got a heart like this, you see, you're not going to die from it, but you're just not going to be efficient. As Sylvie said, well, how do you like exercise? Well, if I have to, People like that, you can't exercise that much, because the harder she exercises, that's not going to necessarily pump, be more efficient. So if this was an athlete, and this is before they go on the track, you imagine they're not going to get that much better when they've been around the track. Okay? And eventually they'll reach a point where there won't be the oxygen there, and they'll sort of grind to a halt. Which happened to that actor the other day, the comedian, isn't it, when he ran? The comedian that died after exercising. Rick Mail, yes. He'd just gone for his run, and then, which must have been a sudden cardiac attack, it was called. Attack of what? Attack of no blood, really, after exercising. So very, very important. If you've got a low first sound, we must try and build this first sound up. So we need to look very carefully at what is needed. And the only person who knows the answer is Sylvie. I can guess, I can think, oh, you might need magnesium, you might need this, you might need that. But in a minute, we'll find out what she actually needs. Because there's only one person we can ask, and that's her brain. So we make her feedback, we make her brain listen to this and say, what do you think of this? Tell me the answer. Okay? Simple as that, really, because your brain will say, well, I need this, or I need to remove certain toxins from my input. Actually, that wasn't yours, was it? Did we swapped back, haven't we? Yeah. Yes, okay. Okay, so oxygen saturation. So the first way we found out hypoxia was such an important part is the fact that so many people on the cardiograph showed very small first sounds. Second one was oxygen saturation. This is a term referring to the concentration of oxygen in the blood. The human body requires and regulates a very precise and specific balance of oxygen. The normal blood oxygen levels should be considered 95 to 100%. That's what they classify as normal. That's not for us. If the level is below 90%, it's considered hypoxia. We'd almost consider that anoxia or lack of oxygen. That's very serious. So blood levels below 80%, the person is often passing out. And in the first place that you tend to see low levels of oxygen is in the cerebellum. The cerebellum has more neurons in it than the whole of the cerebral cortex. So cerebellum means small brain. So it's a small area here which is involved with the vestibular mechanism and subconscious mind. But there's more neurons, which mean it needs more oxygen than anywhere else. So one of the first places when you get hypoxia is you lose balance. And I won't get you to do that, but the way to do this is to get everybody to stand up and to stand on one leg and close your eyes. And most people can't stay up for very long. Okay? We may do that at the end of the morning. Okay. So in medicine, oxygen saturation is known as the SATs. If you ever watch any of the hospital programs on telly, one of the first things they do is what's the SATs after the emergency. It measures the percentage of hemoglobin binding in the bloodstream So around 90%, the value varies according to clinical conduct. Oxygen saturation increases according to an oxygen hemoglobin dissociation curve. Now, this doesn't look too serious. When we get to 90 here, it's beginning to drop. But even a 2% drop from optimal is non-optimal. If you're operating, or you should operate, on 100%, that means you're 2% inefficient, which means you're producing 2%, if you like, less energy at the end of the day. The simplest ways to measure this is an oximeter. Now, these are very cheap, very simple, and very easy to use. Okay, a pulse oximeter relies upon the light absorption characteristics of saturated or oxidized hemoglobin and gives an indication of the level. Okay, so the very simple device that goes onto the nail on usually the index finger. This is how they teach you, and then it'll tell you the pulse rate and the degree of saturation. Now, I've never seen anybody with 100% on there, apart from the lady, as I said, who had oxygen therapy, and I've seen some low ones, you know, in the 80s. Very easy to do. In America, they taught us, the clinic that Jill and I go to put one on each finger. Okay, because they can vary. The oxygen flow to one arm can be different. And I've more recently started putting them on the second toe as well, because sometimes people have cold feet. You can't get it, the machine won't go round the big toe because the nail's too big, but you can put it on the second toe. The second toe has a nail roughly the size of this, so it will actually clip onto the second toe. And sometimes the oxygen level, by the time it's got from here all the way down to there, although the way down there and back only takes 16 seconds, the through journey there is pretty quick, but the pressure may be not as great down there, and so the level of oxygen, people get cold feet and may even develop more serious cyanosis problems. So why I did it there is because I wanted to get a mirror really of what it's like in the brain. Because you've got good oxygenation here doesn't mean in the deepest reach of the cerebellum you've got enough oxygen. Okay, so measuring the finger may not be a total body call. So these are about 15, 16 pounds from Amazon. You can buy them, buy one or two, buy 6 if you want. Okay, a lot of people already got them. So there we can see 98% on here, 56 pulse. Wow. What? Pretty chilly? Chill, yeah. Slow pulse, low oxygen. No, not low oxygen. The 98 is not bad, but a slow. This was a sports person. Okay. If you saw this in a non-sports person, you might get a bit worried. There was a bit too much parasympathetic effect on the heart there. But 98 is not bad, not perfect, but not bad. I hadn't noticed that before. Can you see here the nail, the little skin part there coming back? Does anybody else get that? When the skin on the nail bed just comes away a little bit, you know, just the skin slips, they're called. Yeah, that's P5P, pyridoxal 5-phosphate. Sure sign of it. When the skin splits like that, you've got pyridoxal 5-phosphate deficiency. Okay. Dry skin, sometimes it's just patches of skin, localized areas. Again, sure signs of it. It's funny, it's only when you look at somebody's hand afterwards, you start to see a few little blemishes on a photograph like there. You wouldn't notice it when you shook hands with somebody. Well, there's a skin lesion here, and there's a skin tag there. Okay, so functional ways for us, assuming you do some form of muscle testing, is one of the first ones we came across years ago was when all muscles are weak. Okay, we've all come across patients like that, haven't we? Lay them down on the table, and you breathe a sigh of relief because the first muscle you test is nice and strong. Okay, and you think, oh, they're over the first hurdle. That's great. Now, then a single muscle weakens on repeated muscle testing. So we do a few tests using it, and then they're going weak. And you think, well, that's funny. So you test another muscle and it's gone weak as well. And then everything just crashes on you. All right? You've had patients like that, I'm sure. They just universally weaken, even though you've only been working one muscle, but they all weaken. So they're either weak to begin with, or they weaken very quickly. Positive eyes into distortion up and down. This is an aerobic challenge, which we're doing, right? When you go up and down once a second. So it's an aerobic challenge, and this is a sign of hypoxia. A weak muscle strengthens to oxygen. So this would be the fundamental challenge, wouldn't it? Anything that's weak will strengthen to O2. That's an indication you need oxygen. And therefore, a strong muscle weakens to carbon dioxide, but not always. I don't think carbon dioxide is a good evaluator from strength to weakness for hypoxia. Because remember, if a person has low oxygen, they're going to have produce low metabolism in the cell, which will produce low levels of carbon dioxide. So they may actually have low carbon dioxide and low oxygen. So using carbon dioxide is not the best. But xanthine oxidase as a marker is a sure sign a person's got hypoxia, because xanthine oxidase is an enzyme that's stimulated in hypoxic conditions and will go on to produce superoxide and nitric oxide. So I like, if you want to verify and go from strength to weakness with a person, to change them to weakness and talk hypoxia, xanthine oxidase is the best way. These are all in the phonocardiography kit. Those who bought phonocardiography kits before, there's a few upgrades which we've done with all these hemoglobin markers and xanthines and things.